Hello and welcome to our program entitled What Now, What Next? Efficacy and Safety of Approved and Emerging BCMA-directed Therapies in Multiple Myeloma. My name is Dr. Joseph Mikhael. I am a professor at the Translational Genomics Research Institute and the Chief Medical Officer of the International Myeloma Foundation. And it's a pleasure for me to be the moderator of our program today, which is supported by educational grants from Janssen Biotech and from Pfizer. Joining me today are two outstanding myeloma physicians who also happen to be very good friends of mine. I think the world of them, and it's just a pleasure to have them with me. I'll let them quickly introduce themselves. First of all, Dr. Nina Shah.
Hello, my name is Dr. Nina Shah from the University of California, San Francisco in San Francisco, California, where I'm part of the Multiple Myeloma Translational Initiative.
And secondly, Dr. Surbhi Sidana.
Hi, I'm Dr. Surbhi Sidana. I'm an assistant professor at Stanford University, and I lead the myeloma CAR-T program here.
Great. Well, thanks so much. It's so good to have both of you with me today, and we really look forward to this program. And indeed, this is a part of a two-part program on BCMA-directed therapies that we'll be telling you more about as we go through. Here we have our disclosures, and we always think it's very important to make sure that these are abundantly clear to all. And as I mentioned, this is a part of a two-part series where we look at BCMA-directed therapies in myeloma, and we have another live stream next week. Check it out, and the associated tutorials that come with it at @BonhamCE Twitter pages to follow that program. Our learning objectives for today are as follows. Upon completion of this educational activity, we trust that the participants should be able to differentiate BCMA targeted therapies based on their mechanism of action. And secondly, to compare clinical trial design, participants, and outcomes of BCMA-directed therapies. So as we think of BCMA, or B-cell maturation antigen, there's been a lot of enthusiasm around BCMA over the last several years in myeloma because it is such a prolifically expressed antigen on the surface of myeloma cells. So we've tried to diagrammatically capture it all in one visual here, where you see the multiple myeloma cell that is expressing this blue BCMA on its surface. And there are different ways, as we're going to be describing, how we target that, whether we target with an antibody drug conjugate, whether we target it through a CAR T-cell therapy, or whether we target it through a bispecific therapy. When we think about antibody drug conjugates, we know that in particular the conjugate we'll be discussing with belantamab not only adheres to that BCMA, but then has a toxin, that drug that's conjugated, that it can drop into the cell so that it can help destroy the cell. We have different ways of targeting the cell all through BCMA, but three very different capacities. So before we dive into data and think about it in more detail, let me ask our two experts who are with us today. There has been so much advance in myeloma of late, but in particular in this area of triple class refractory multiple myeloma. And I just want to kind of get your gut feeling before we dive into the data. And maybe I'll start with you, Nina. What is your sort of rationale of thinking to triple class refractory disease? How do you, all those patients, of course, aren't exactly the same, but what is your sort of initial approach once you see a patient has been exposed to and refractory to proteasome inhibitors, immunomodulatory drugs, and CD38 monoclonal antibodies?
Yeah, Joe, it's a great question because as many trials and results as we have, it's still an unmet need. Those patients really don't have enough therapies that are available. Yes, we have cytotoxic agents, but it really comes down to what has the patient received and what have they tolerated. And for a lot of those patients, that's a very small bucket of things that has both of those qualities where they haven't received it and they would be able to tolerate it. So it's a very nuanced personal decision as you made. As you stated that we make for the patients, or we help the patients make. And I think that's why immunotherapies are so important, because they give us another tool, another weapon in this very, very difficult patient population.
So Surbhi, similar question to you. I'm thankful we have choice now, right? I'm old enough to remember, well, before the two of you got involved in myeloma, I can remember the days where triple class refractory didn't exist, but even more recently, the patient came to triple class refractory setting and we had very little to choose. What guides your treatment more than anything else when you're trying to decide what to give their patient next, especially, let's say, if it's going to be a BCMA-directed therapy, whether it's an ADC, whether it's a CAR T or maybe even on clinical trial now with a bispecific?
So I think that's a great question, and I'm glad we have so much choice now that we didn't have in the years prior. I think that's a sign of progress for our patients and for our community. And I would like to echo everything what Nina says, but especially focus on individualizing it. So individualizing it to what the patient wants, what their comorbidities are, and can they travel? What's their access like? And so, a CAR T trial or a CAR T therapy might be great, but if a patient can't travel, we have to meet them where they are and give them the therapy that they need. So maybe for that particular patient, a BCMA antibody drug conjugate might be better if they can't travel, versus if they can travel, you might have other options like bispecific trials or CAR T. And of course, depending on their comorbidities as well and what they, focus on in terms of their quality of life and side effects.
Brilliant answer, as to be expected from you. So thank you. And that actually is a great segue into this first case that I'm going to present. And it's a case that we're going to kind of modify as we go through and make some changes. What if this were present? What if that were present? But it reminds us that, as I always say, we don't treat myeloma, we treat people, and how we make that adjustment to be individualized, as you well stated, Surbhi. So thank you for saying that. So here's our case. This is a 66-year-old African-American woman. Remember, myeloma is twice as common in the African-American community than is in the Caucasian community. And she presented initially with fatigue and anemia. She had an ECOG performance status of 1, but thankfully normal renal and hepatic function. She also had translocation 11-14, and she was an ISS stage 2 with an IgG kappa predominant myeloma. So she received what would really be standard therapy. She received a VRD regimen, bortezomib, lenalidomide, dexamethasone. She had an autologous stem cell transplant. She went to lenalidomide maintenance. Since then, she's had 3 more lines of therapy with subsequent relapses of daratumumab, pomalidomide, dexamethasone, carfilzomib, cyclophosphamide, dexamethasone, and then most recently, elotuzumab, pomalidomide, and dexamethasone. So going to what Surbhi just shared with us in terms of treatment considerations, she's had 4 prior therapies, but she prefers to receive her therapy locally. She unfortunately does have a persistent grade 1 peripheral neuropathy, and she's pretty concerned about the ability to afford oral medications. As we know, there's often a significant disparity in the cost of oral versus intravenous or subcutaneous options. And so when we look at this triple class refractory space, 4 prior lines, 4 big options jump out to us: belantamab mafodotin, ide-cel as a CAR T-cell therapy, selinexor and dexamethasone, or potentially venetoclax, albeit not formally FDA approved, off-label in the sense that it's approved in other diseases. And then just more recently, we've had to the CAR T-cell therapy world added cilta-cel. So as we think about these options, let's think a little bit, first of all, about the ADC, or the antibody drug conjugate, belantamab mafodotin. So this is, of course, BCMA-directed, and this was based on the DREAM2 study, which was a 2-arm, open-label, randomized, multi-center study of 2 different dosing strategies, either 2.5 mg per kg or 3.4 mg per kg, with a little under 200 patients ultimately receiving the treatment. These patients had had at least 3 prior therapies and were indeed refractory to proteasome inhibition and immunomodulatory drug, and either refractory or intolerant to CD38. So very much what we'd expect, that triple class refractory space. And when we look at those baseline characteristics, we saw that a significant proportion, no surprise, as more patients become more high risk over time, a significant proportion of patients were high risk at 42%. The range of prior lines of therapy was from 3 to 21, but the median was 7 prior lines of therapy. Almost everybody had had a transplant, and everyone was indeed triple class refractory. So with just this single agent therapy, we saw a 32% response rate, which of course compares very favorably to therapies that have been used in the space before. The progression-free survival was approximately 3 months, a median of 2.8 months, with an overall survival of nearly 14 months at 13.7 months. Now, in terms of adverse events, this is what has gotten us thinking a little bit more and working a bit differently as hematologists. We did see hematologic toxicities that tended not to be very high grade, but important to watch nonetheless. As you see here, particular of the thrombocytopenia, 22% had grade 3 or higher. But the new, if you will, toxicity for us to learn about was the ocular toxicity. We'll discuss this significantly more in our second session. but where 72% of patients had some degree of keratopathy and nearly half had grade 3 or more. And about 50% of patients did have either reduced visual acuity, blurred vision, or a dry eye. There were, as you can see here, a relatively low rate of significant infusional reactions. When we think about this patient, as we have discussed before, she's 66 years old. She had had all these prior therapies before, and now she's at a stage where she needs something for a triple class refractory disease. Belantamab mafodotin is a very reasonable option. She wanted to be treated locally. This allows local treatment. She was concerned about oral therapies. This is given intravenously every 3 weeks. And so, interestingly, she's treated. She receives a partial response, but unfortunately does develop a grade 3 keratopathy, which of course will require a dose delay and reduction. And eventually she progresses on this. But in thinking about this case together as a group, I'd like us to think a little bit about this of now you have this patient, Nina. She's been treated with all of her prior therapies, and now she's been treated with this BCMA-directed antibody drug conjugate. I know it's a little bit early and a lot of the studies haven't been done, but you're so experienced, both of you are so experienced in this realm. What is your feeling about going from BCMA to BCMA? In your mind, are you thinking, if she's willing, I may take her to, a CAR T cell therapy or even maybe a clinical trial with a BCMA bispecific? What is your feeling about that sequential concept?
Yeah, this is a question that's coming up a lot nowadays, especially because we have various BCMA targeting agents. And you're right that belantamab mafodotin is one of the easiest to use in the sense that it's off the shelf. So a lot of patients are getting that. And I actually think that it's totally reasonable to consider another BCMA targeting agent after you have had one. We know from some of the correlative data that actually BCMA tends to still be on the cells. And there are a few patients who lose it, but those are sort of individualized, there's kind of one-off cases from what we can tell in a lot of the literature. We got to put it all together, but it seems that patients still have BCMA on their cell surface, and it makes sense to try to attempt with another agent that might be even more effective or be better able to engage with the BCMA on the surface. So I would consider maybe another BCMA targeting agent for this patient who had progressed on belantamab.
And Surbhi, basically same question to you. Are you comfortable? Have you had some experience going from one BCMA to another? Would you feel comfortable offering her another BCMA strategy here?
So yeah, I 100% agree with Nina, right? In lymphoma, we are seeing a lot of CD19 loss after CD19-directed therapies, but we're not seeing that much in myeloma. So BCMA is still preserved after BCMA-directed therapies. We have emerging data that BCMA therapies might be effective when done sequentially. It's probably preferable to change to a different type of BCMA therapy than try to do the same BCMA therapy twice. And we can come to that later. If you try to do CAR after CAR, probably not the best idea, but if you want to do an antibody drug conjugate followed by a CAR, probably a better idea in terms of cross-resistance due to other reasons.
Excellent. Yeah, no, I think your points are very well taken and very important. And I know a lot of colleagues that are working very hard on this to try and understand this better, what leads to BCMA loss in contrast to the CD19 loss that you mentioned in lymphoma, where it seems to happen in a pretty small percentage of patients in the realm of about 5% who really get that true BCMA loss. Well, Surbhi, in just a minute, I'm going to give you the power here to present and to talk us through a little bit more in CAR T. But before we do that, let's just go back to the case and let's change the case for a moment. So let's pretend that she's in a situation where she's triple class refractory and she's had 4 prior therapies, but now let's say she's a photographer. And let's say that she's actually willing to travel to cellular therapies, and she actually has relatively good organ function and is ready for cellular therapy. So in contrast to what we'd heard before, maybe she might say, because I'm a photographer, I'm very concerned about ocular toxicity. Before she said she didn't want to travel, now she's willing to travel. Why don't you walk us through a little bit what your approach would be in thinking about and offering this patient CAR T cell therapy? So I will turn it to you to walk us through that.
Thank you. I think, patient preference changes a lot of things as we talked about earlier in the program. So let me walk you all through CAR T cell therapy. So again, this slide shows the different mechanisms for BCMA targeted therapies for myeloma, one of which is CAR T cell therapy. And the first CAR T-cell therapy to be FDA approved in myeloma was ide-cel. It was FDA approved in March 2021, so a year ago, based on the results of the KarMMa study. And so the KarMMa study was a phase 2 single-arm trial, which included 128 patients who were triple-class refractory, and out of these patients, they were treated with a varying cell dose of 150 to 400 million CAR T cells. These patients had to have received 3 prior lines of therapy, have good performance status, and had PI, IMiD, and anti-CD38 therapy in the past. When we look at the results of the KarMMa trial, this was a very heavily treated patient population with a median age of 61 years, with a median of 6 prior lines of therapy. 35% of these patients were high risk, and majority of them were triple-class refractory. 26% were penta refractory. And in this heavily pretreated population, we saw response rates of 73%. Again, this was unprecedented in this population and was very encouraging to see. 33% patients actually got into a CR, and unheard of before, 26% of patients were MRD negative after ide-cel in this heavily pretreated patient population. When we look at the progression-free survival and overall survival, the median progression-free survival was about 8.8 months. It was longer if you got into a deeper response, so 20 months if you got into a CR. And when we look at overall survival, the median overall survival right now is about 2 years. So I think very encouraging data for a very heavily pretreated population. In terms of side effects, this is a new modality of therapy, so there are new and unique side effects. When we look at hematologic side effects, almost everybody got some hematologic toxicity. But important to note that beyond the first month, about 40 to 48% of patients still had grade 3 or 4 neutropenia and thrombocytopenia beyond a month. So what does that mean? That means that the patients might need growth factors beyond a month, they might need platelet transfusions beyond a month, and may need to be watched carefully. Cytokine release syndrome, which is common with all CAR T-cell therapies, was fairly common, but thankfully it was mostly grade 1 and 2, with only 5% of patients having grade 3 or 4 CRS. Neurotoxicity was seen in 18%, with only 3% having grade 3 or 4 neurotoxicity, making this very manageable. Because these patients are immunocompromised, infection is fairly common, 69% in the KarMMa trial, 22% patients having grade 3 or 4 infection. So that was one CAR T construct. Earlier this week, we had a second CAR T construct FDA approved, which is cilta-cel, and this is based on the results of the CARTITUDE-1 study design. It's again a phase 1B and 2 study design. They treated 97 patients, 29 in phase 1, 68 in phase 2. Again, this was a very heavily pretreated patient population with a median of 6 prior lines of therapy. 88% patients were triple-class refractory, 42% were penta-refractory. And in this heavily pretreated population, we again saw an astounding response rate of 98% and a CR rate of 83%. Again, for this population, we really don't have any comparative data for that. When we look at progression-free survival and overall survival, we don't have median numbers, but at 2 years, the progression-free survival was 61% approximately, and at 2 years, 74% of patients are still alive. And I think for this patient population or any population in myeloma, this is very encouraging. When we look at safety, we again note similar side effects with hematologic toxicity seen in most patients. And when we look at that 1 month or beyond time point, which is important as patients transition from the CAR T center back to their local doc, grade 3 or 4 neutropenia, which means a neutrophil count less than 1,000, and grade 3 or 4 thrombocytopenia was seen in about 30 to 40% of patients, meaning this requires monitoring, may require growth factor and transfusion support. Cytokine release syndrome occurred in virtually all patients, so 95%, but was mostly grade 1 and 2, with only 4% patients having grade 3 or 4 CRS. Neurotoxicity occurred in about 21% of patients. And in this construct, it's important to note there were 2 different types of neurotoxicities. One was the classic ICANS, which occurs early and then is resolved usually by 2 weeks. It occurred in 17% of patients, grade 3 or 4 and 2%. But then we also saw these other neurotoxicities, which were delayed onset. They started usually about day 27, 28. And this occurred in 12% of patients, grade 3 or 4 and 9%. These included neurocognitive and movement disorders. Now, we have identified certain risk factors for these neurotoxicities, and with mitigation measures like more effective bridging and lower disease burden going into CAR T-cell therapy, we have not seen this with cilta-cel anymore, which is very encouraging. Infection, again, is very common as these patients are very immunosuppressed in 58% of patients, grade 3 or 4 in 20% of patients. So I told you about two very exciting CAR T-cell constructs, which are now FDA approved. And while that is wonderful news for myeloma patients, there still exists a lot of barriers to CAR T-cell therapy. One of them is that these therapies are highly specialized. They need a big infrastructure and can only be given at certain tertiary centers, meaning most patients need to be referred to a tertiary care center for CAR T-cell therapy. And even if that happens and patients are willing to travel and relocate for a month or 6 weeks for that, there are other barriers. There needs to be collection, and then the manufacturing time is 4 to 6 weeks. So you need to stabilize a patient's disease. And even if we do that right now, the biggest barrier in 2022 is the availability of CAR T slots, because you need special viral vectors for CAR T manufacturing. It's a highly complex process. And so right now we have many more patients who need these therapies than what we are able to provide. And once we do all of this, patients need to have the infusion, stay around the CAR T-cell therapy center, and then there needs to be an effective transition from the CAR T-cell therapy center back to their local doc for co-management. So I think there's a lot for us to learn and a lot we can improve on in terms of access and availability of these therapies for our patients. There's multiple different CAR T-cell therapy studies ongoing, both targeting BCMA and also targeting non-BCMA targets. And I think we'll hear more in the coming years about these exciting constructs. So with that, I'll pass on to Dr. Mikhael to discuss the case further.
Great. Thank you so much, Surbhi. Thank you for putting it in such great context, between seeing really remarkable response rates and length of response. I mean, this is just not what we've seen historically in multiple myeloma, that people could go 1-2 years when maybe their survival was only expected to be 6 to 8 months. So it's really impressive, but yet giving us that caveat at the end about some of the challenges that we have with access. And so I appreciate that you shared that with us. So if we bring up the case here again and look and see that now that she was willing to do so and she was able to get therapy with CAR T-cell therapy, she went and had cilta-cel therapy. So she achieved a stringent complete remission, which, as we heard, was a significant fraction of the patients on the study. She developed grade 2 CRS, which was quite manageable, and she got 2.5 years of progression-free survival. So really quite an impressive story, something that would have been kind of beyond our thinking as recently as just a couple of years ago. But to think about this a little bit more, and Nina, I'm going to turn to you. Surbhi made reference at the end of her presentation about some of the kind of supply chain-like issues, viral vector. This is a real challenge. It has been a real challenge. And so my question to you is twofold. One, what have you been doing to try and overcome this? Have you used prioritization strategies and so on in the patients that you have? And then two, if I could make you prophet Nina for a minute, I mean, looking at future, do you think we're going to get beyond this? Do you think things are going to get better in the near future?
Yeah, these issues of supply chain, et cetera, if you will, are part of the real world rollout issues, right? You can do whatever you want on clinical trial, but what happens in the real world is really that's part of it. That's why people follow up afterwards. So I think that the supply chain of this is going to make us think of innovative ways of culturing and producing these cells. And one of the things that's being done actually across many of these companies is to try to shorten the time that it takes to manufacture these cells. And the reason that's important is if you can take something and make it go from 2 weeks to 1 week of manufacture, you've now doubled the amount of capacity that any one company has, which makes it easier for you to then give this out to more patients. And that being said, you're still not going to be able to treat all of your myeloma patients with this therapy. And so trying to figure out which patients are the best is another thing that really has to be done. And in order to understand this better, we've really started to look at some correlative data, not just correlative data from the actual cells or from the the vector, et cetera, but actually from patients, clinical factors. And we now know that patients, for example, who were treated with ide-cel, who had lower beta-2 microglobulin or lower serum BCMA, in combination with a better transduction efficiency or vector copy number, actually did better and were more likely to achieve a complete response. And getting more and more data like that will help us to figure out which patients should actually be getting CAR T therapy to get those great responses. And then maybe other patients can get other types of therapies for which they don't necessarily have to come and get apheresed, et cetera. So honing down our ability to be better clinicians, and then the companies honing down how they're going to make the culture better. I think both of those are going to chip away at the supply chain problem that we have.
Yeah, no, I agree. I mean, I think at some point we were able to get toilet paper at Costco again, right? I mean, eventually the supply chain gets caught up. Not that this is by any means a similar product, much more complicated, but I do think that pragmatic point is so critical, and we'll explore in our second program more some of the true other access like issues, some of which that Surbhi mentioned around geographical access and sadly racial access. We've seen that African Americans are less likely to receive autologous stem cell transplant, and thus far they're also less likely to receive a CAR T cell therapy. And so I think dedicated strategies and ways to overcome that will be really important as we go forward. Well, let's come back to the case now to introduce what you're going to share with us, Nina. So I know she seems to be changing her jobs quite regularly, but now let's say that she's an accountant. Right. And so back to this situation where she is triple class refractory, she's had 4 prior therapies, but now what's different is she cares for her grandchild. And so she's really not able to get to a CAR T center. So now going to CAR T cell therapy with Surbhi, despite the great response rates and progression-free survival, that's just not an option for her. She's also hypogammaglobulinemic, which may influence some of our thinking in CAR T cell therapy. And so with that in mind, could there be another strategy, Nina? Could there be another way of approaching the myeloma cell through BCMA targeting that is not via CAR T? And of course, the answer is yes. And that's going to be your opportunity now to talk to us about bispecific therapies.
Thanks, Joe. This is a really exciting time for immunotherapy for multiple myeloma. And if we go back to our diagram here, you can see that there are multiple ways to get to the myeloma cell using BCMA targeted therapies. And I want to focus on one of these specifically, which is the bispecific antibody. Now, this is a molecule, an off-the-shelf molecule that binds both to CD3, which is on the T cell, and BCMA, which is on the target myeloma cell. So as to get them to be more proximal to each other. And this allows for the T cell and the myeloma to have cross-linking, which ultimately allows for the T cell to be activated, release excitatory cytokines, and then trigger apoptosis towards the target cell. So a really nice, elegant way of applying immunotherapy in an off-the-shelf manner, sort of the best of an antibody by engaging not just the specifics of the myeloma cell, but also engaging the T cell to help to kill the myeloma cell as its target. So what do we know about these particular molecules? It's suffice to say the T cell engagers have had just a burst of data for the past 2 years. They really, in a way, have overcome the CAR T cells as far as the number of trials, the number of agents available. And I'm going to try to go through this fairly quickly, but just to get an idea of what's been going on. First, we have the Majestic-1 study. So this is a drug known as teclistamab, also known as J&J 957. And this is a bispecific antibody, again, against BCMA or B cell maturation antigen, as well as CD3. So it brings together the T cells against the myeloma cells. Looking at this study, this was a single arm, open label, multi-center dose escalation study. So it's phase 1 and phase 2 for patients with relapsed refractory myeloma with at least 3 prior therapies. They had to be exposed to all 3 of your classic novel therapies, PI, IMiD, and anti-CD38 antibody, but of course, no prior BCMA therapy. Now, this is a phase 1, phase 2. So initially they were looking at safety and in their dose escalation, but then did look at overall response rate in the phase 2. Teclistamab is given as a weekly subcutaneous administration. So this is given weekly to the patient after a few step-up doses. And in the phase 1, they had 40 patients enrolled in this 1.5 mg per kg cohort, for which they went forward for the phase 2 to get additional safety and efficacy analyses. So they really have a lot of data in this particular study with an efficacy analysis of 150 patients, an additional 15 patients of 165 for the safety analysis. So what do the results show? First of all, I want to point out that these patients are very heavily pretreated, very similar to the CAR T cell therapy studies that you've heard about, with a median prior lines of therapy of 5. So that's a lot of lines that these patients have gotten. Most of them had had transplant before, many of them triple class refractory, and a number of them penta refractory. Now, if you look on the right-hand side, you can see that the overall response rate is 62%. And I just want to point this out. Remember, this is a phase 1/2 study, a single agent therapy. These are numbers that we rarely would have seen in prior history of myeloma drug development. So very exciting, 62% overall response rate with VGPR or better of 58% and CR or better of 29%. So really impressive data for this particular agent. Now, we don't have a lot of duration of response data because we don't have very long follow-up yet. But what we do know is the duration of response is really edging towards something very impressive here. You see the median has not been reached yet, even at the 12 and 15-month mark. I think that really maybe there are patients that are going to have just as long responses to the T cell engagers as patients have had with CAR T cell therapy. And that remains to be seen. But definitely this is a new player on the scene, a new mechanism of action, and as I mentioned, off the shelf. Now, what about safety? Of course, these work also by engaging T cells. So we want to make sure that we look out for the toxicities and side effects that you would expect from anything that does engage T cells. So similarly, as the CAR T cell therapy data, you can see that there are hematologic and non-hematologic AEs. So hematologic AEs, of course, neutropenia, thrombocytopenia, that's sort of the name of the game in hematologic malignancies. This is something that we expect, and it does happen. Any grade somewhere between 30 to 66%. Grade 3 or 4, these things do happen. Again, we expect neutropenia from a lot of our therapies, not so surprising, but definitely manageable. Something you have to keep in mind because these therapies aren't just one and done, right? They're serial therapies. So there are patients who may have neutropenia here and there during the course of their therapy. You have to remember to expect it. Now, cytokine release syndrome, which is something that you expect with T cell engagement, does happen. And in this particular study, happened in 72% of patients, but was generally grade 1 or 2. Very few, if any, cases of grade 3 or 4. Neurotoxicity, we find this to be sort of interesting with the bispecifics that tends to be a little bit less, so 13% neurotoxicity, and they included things like headaches, so that might not even be what we would consider to be ICANS, and generally low grade for all of these. Patients do have infections. I think that's something that you really have to think about for long-term therapy. So about 2/3 of the patients had infections. A lot of patients do have hypogammaglobulinemia, and this comes from the intended B cell aplasia, sort of a bad thing and a good thing, right? But we need to make sure that we think about this as far as supplementing them with immunoglobulin. And then there were some patients with infection site reaction, of course. So this is not the only player as far as T cell engagers go. As I told you, there's just been a burst of new agents that have been giving data for various conferences and also that we now know are in development, which is great because I think that's going to give our patients more options. So here we have the Regeneron 5458 study. Again, a single arm phase 2 study with relapse refractory myeloma, very similar to Majestic study, exposure to all 3 novel agents and double refractory to an IMiD and PI or progressed after CD38 antibody. Now, of course, this is a phase 1. So the primary endpoint was safety and trying to find the RP2D. You can see how they had their dose escalation and their steps going upward. Now, this is weekly IV for the first 16 weeks, and then every 2 weeks until progressive disease. Now, I'm making a big deal about the dosing scheme and regimen and administration, but this is ultimately what it may come down to for patient preference. So what happened with the results? Again, this is a very heavily pretreated patient population, and they had 5 prior lines of therapy as their median prior lines. Again, a lot of patients had had stem cell transplant before, many of them triple and penta refractory, and most of them refractory to their last line. Now, if you look at the different dose levels when you're looking at overall response rate, remember, these are phase 1 studies, so it's hard to interpret all the data, but look at the higher dose levels, which are considered to still be safe. You can see an overall response rate of 75%. Again, single agent, very impressive, things that we want to think about as far as, previously we think of 30% being one of the sort of standards at which a drug had to perform. And these are at 60 and 75%. Again, very short duration of follow-up so far, but it seems like the patients are, many of them, staying in response with continued responses as seen by the black arrows. We're looking forward to longer follow-up. And when we look at the safety, again, cytopenias have been seen. CRS here a little bit less, 38%, and neurotoxicity in line with what we've seen before, around 21%, but most of it is really headache. ICANS tends tends to be very low at 4%. Now, there are other BCMA bispecifics on the horizon as well. This is the Abbvie-383 drug, previously known as TNB-383B. Again, single arm phase 1 study to understand safety and ultimately determine RP2D. You can see here the various dose levels that were tested. Now, what is different about this particular agent is that it's IV, but every 3 weeks. This gives a little bit of a more stretch of time. We had the weekly teclistamab and the every other 2 weeks with Regeneron. Now we've got every 3 weeks. And then this was given until PD. Now they looked at a dose expansion level of 60 milligrams, but really focused their data on the 40 milligram or higher. Again, very heavily pretreated patients, median prior lines of therapy of 5. Many of them were refractory to double and triple drug classes, and a lot of them were then progressing at the time of the study. If you look at overall response rate, just to kind of put this together, if you take all the patients who got at least 40 milligrams in both the escalation and the expansion, you can see that the overall response rate was 81%. Now, if you only take the patients in the expansion and the escalation with 40 milligrams or more, those patients had an overall response rate of 60%, whereas the patients in only escalation had a response rate of 81%. And this sometimes happens. You'll see that patients tend to respond maybe in the escalation, and it's a little bit less in the expansion because of the kinetics of how patients are enrolled in these trials. It tends to be a little quicker in the expansion because you don't have to wait so much between the dose levels, so that there's a little bit less cherry picking, if you will, that goes on sometimes in these particular slots of the study. So if we look at the duration, again, we don't have too much duration follow-up yet, but what we can see is patients are doing pretty well, especially at that 40 milligram or higher dose. And you can see that it seems that the median hasn't been reached yet if you talk about only the 40 milligram dose. So we're excited to see what happens with this particular agent. Seems to be fairly safe, very similar cytopenias, CRS right in line with what we've seen, about 70%. And again, ICANS in 3%, but a lot of the neurotoxicity tends to be related to headache, and they did have some infections. Again, very interesting to see because these are serially dosed things, not just one time. Have to keep on top of it with thinking about infections. Now, another drug that's on the horizon is Elrene, which is also a BCMA bispecific T-cell engager. And this has been studied in the MagnetisM-1 study. Again, phase 1 study with relapsed refractory myeloma. All patients here had to have at least 3 prior lines of therapy with a primary endpoint, again, looking at safety, tolerability, trying to get to the RP2D. Now, this is given subcutaneously every 1 or 2 weeks, depending on how the dosing was done there. And then they had another dose expansion where they looked at a priming dose, then followed by a higher weekly dose. The dosing was a little bit complicated in this study, but ultimately they were able to focus on this cohort of 55 patients, again, very highly refractory patients with a median prior lines of 6, most of them triple class refractory. And you can see here that the Elrene overall response rate was 69%. And one of the things that I thought was very interesting about this study is that they had 22% of patients that had had some kind of prior BCMA therapy. And we talked about this a little bit, and those patients did have some responses. So there were some patients who did respond despite having had prior BCMA-directed therapy, which I think leads us to think that, okay, we can maybe switch between classes as we were talking about, even though it's the same target, which then expands options for our patients. When we look at the response duration of the MagnetisM study, again, very short follow-up, so it's hard to see, but there are patients that are continuing to respond, particularly when you see at the higher doses. So look forward to some more long-term follow-up from this study. Now, we know that there are different ways to dose this drug. You can either do it weekly or it's every 2 weeks. And another factor that may change their safety, as you'll see later, is whether they do a priming dose with pre-medications or not. And now this is something that's being worked out a lot between all of the different T-cell engagers, because you might be able to get away with different dose schedules, maybe not every week, but every 2 weeks. And you may be able to get away with better safety signals if you give a little bit of dose upfront and then give to a higher dose, so what we call step-up dosing. So you can see from the safety data from MagnetisM that they also had cytopenias, and they did have CRS at 87% with some injection site reactions, but they look to be much better when they look at their 2-step priming regimen, which they think are going to be able to have lesser CRS for that particular agent. So we look forward to more follow-up from that drug with this new dosing regimen. Now, we also have another drug that's been studied. This is the CC93269, or what they call 269 for short. Again, a BCMA-directed bispecific T-cell engager. Again, very heavily pretreated patients here. This is a phase 1 study looking to evaluate safety and tolerability of this agent, and also looking to determine the RP2D. Patients had to have at least 3 prior regimens with no prior BCMA targeted therapy. This dosing is kind of similar to what we've seen with daratumumab in the past, with initially weekly dosing IV, and then it gets to every 2-week dosing, and then ultimately can go to monthly dosing every 28 days. So something to think about, because if people are going to be on therapy for 2-3 years, they may not want to come more frequently than once every 3 or 4 weeks. So you can see here how the doses were determined. They had studied up to 10 milligrams. We don't have too much updated data, but we know that the patients were very heavily pretreated with a median of prior lines of therapy of 5, and many of them were refractory to daratumumab, PI, and IMiD, or triple class refractory, about 2/3 of them, and all of them were refractory going into the trial. Now, if you look at the overall response rate for the patients who were topped out at either 6 milligrams or 10 milligrams, you can see that at the 10 milligram dose, the overall response rate was 89%. So very impressive data here, and something that we look forward to getting even more data as time goes on. Safety events, of course, as you can see, cytopenias are an issue. CRS, very in line with what we've seen already, 77%. And some patients did have infection, about 57% of patients. So there are a lot of similarities in this data. It's kind of hard to put them all together, but these are the kinds of things that we try to think, okay, what is going to separate each of these from the other? And I think a lot of it might end up being how the drug is given, not just the safety profile, but how the drug is given from a logistics profile. So we look forward to that. We know that the future of bispecific antibodies is not limited to BCMA and T cells. We know that there are agents out there targeting GPRC5D and FcRH5, so new targets, not just BCMA. And then we have not just T cells, but maybe NK cell engagers, different ways of engaging NK cells, maybe different ways that the FC portion is engineered to make it more long lasting or not, maybe just using 2 FAB portions, et cetera, trying to change the kinetics, which could modulate both the CRS and how long we have between intervals between dosing, which ultimately could change patient experience. So with that, I want to turn it back over to Joe and maybe talk a little bit more about these really exciting agents on the horizon.
Wow, that was fantastic, Nina. I mean, there's so many molecules. I've been involved in myeloma research for 25 years. I don't think I've ever had a year where we've had as exciting a series of data as we have right now. And congratulations on keeping all the letters and numbers correct too, because you did that flawlessly. So, Surbhi, you heard obviously, and I know you know most of this data already, what Nina just shared. Let me ask you the question that no one can really answer, but we'll try and get someone's take on it is, looking forward, is it going to be CAR T or is it going to be bispecific? Are one going to lead over the other? We see that every one of them have strengths and weaknesses, but do you think that's the way we're going, that we're going to end up choosing one or the other? Or do you think both are going to be with us long term? What's your sense of all of this data and how it's going to apply to us clinically?
Yeah, I think that's the $1,000,000 question. And, we tell our patients we don't have a crystal ball, but we all try to, are coming up with something. There are key differences, and myeloma being a treatable but not curable disease, I think it's great we have all of these options that we can eventually use for our patients. And so the bispecifics right now, they are still needing to be given at academic centers, but I'm hoping as they're FDA approved, they can be given more in the community centers. They might require hospital admission for at least the first 2 doses, but then are more feasible in the community. The CAR T cells require a lot more infrastructure and so are really suited for tertiary care academic centers. So I think that's a key difference in terms of access. In terms of, being patient-friendly beyond access, it's great to have CAR T as a one-and-done therapy with a PFS of 9 months and beyond 2 years, although the response rates with bispecifics are also very encouraging. So I think we have to individualize, and at the end of the day, it will depend on the patient, where they live, how much are they willing to travel one time versus recurrent travel to an infusion center. And I'm hoping with other, non-BCMA targets, or even with some BCMA targets, we can do one and then do the other when one stops working, because none of these are curative therapies at present. We might end up using bispecifics, I think, more though in patients who are frail and perhaps who have renal dysfunction, because it's very challenging to give CAR T cell therapy in those settings.
Well, you've captured so many of the key points. Nina, I'll let you comment on this as well, and also kind of get your take. Patients love this idea of like a one and done and not having to have ongoing therapy. But some are talking now about getting a CAR T and then trying to maintain it with bispecific. Do you think that could be a possibility in the future? I mean, I'm old enough to remember the days we started doing stem cell transplant. We didn't even conceive of maintenance therapy, and then we added it later. I mean, could that same thing happen here?
Yeah, I think that's totally possible. And it's not just bispecifics as a maintenance therapy. There are trials looking at immunomodulatory agents as maintenance therapy after CAR T. And those are great. And whatever can extend life and progression-free survival would be awesome. But I really like this idea of the one and done. And I tell you, and that you said we don't treat myeloma, we treat patients. And these people have lives and they want to go to weddings and go on vacations and go to Alaska and all these things. And it's great if they don't have to come to the chemo suite. They love you, but they don't want to see you that often. So if I like this idea of trying to see how far we can get with the CAR Ts that we have. Certainly, we don't have all the data yet from cilta-cel, but it looks like it's going to be 24 months. And if I could give a patient a therapy without that, without extra therapy, just for 24 months, just straight one-time treatment, I would do that. So I look forward to improving with maintenance therapy, maybe for some risk category patients, but I'd love to see if we can make CAR Ts even better so that patients don't have to come see us as frequently.
No, I agree. I joke and sometimes say, my favorite treatment is nada, nothing. And patients love it. It always gets approved by insurance.
Yeah.
Patients are very adherent.
Yeah, approved.
Indeed. Maybe last question, Surbhi. What do you think about some of these studies that are starting to emerge now with bispecifics in combination? Do you think that's just pragmatic as one company makes both and they want to use both drugs together? Or do you think there's good rationale to combine an antibody with the other antibody with these bispecifics or immunomodulatory drugs or others?
Yeah, no, I think this is very exciting. In myeloma, we've always seen, when there's something single agent, it's great, but when we add other things, it's even better. So more is better in myeloma so far. Triplets are better than doublets, quadruplets are better than triplets. And I think here we'll see the same story. Like the talquetamab, teclistamab combination that we're seeing in trial, the daratumumab combination with the bispecifics that we're seeing. I think this is very, good that there's good safety data, and hopefully we'll have better efficacy data than single agent. So I think I'm very excited.
That's fantastic. Yeah, and of course, I'm sorry that I've asked you both to be prophetesses looking into the future, but I think you've answered those questions really well. So just in summary here, we have a table that can really guide us, trying to put everything or much of what we've shared together all in one table. Looking at these BCMA-directed therapies, we have antibody drug conjugates that are off the shelf or given very conveniently in the outpatient setting, at least now once every 3 weeks, that have minimal infusional reactions and cytopenias are mostly manageable, but keratopathy is an issue, requiring that they see an eye specialist before each dose, where half patients will have some kind of symptomatology from it. And we're not really relying on the patient's own T cell response. At the other extreme, we have CAR T cell therapy that we heard from Surbhi about, where this is obviously much more involved, requires the apheresis. Patients are clearly inpatient for at least a week, sometimes longer. We have to manage CRS and other neurotoxicities and other potential challenges, but we're seeing extraordinary response rates and duration of response. And then in the middle, we have these bispecifics that kind of bridge these two concepts where, again, off the shelf, some IV, some sub-Q, we're still trying to figure out in what setting and what's the optimal dosing, not yet FDA approved. Obviously some CRS, but lower rates than what we've seen with CAR T cell therapy. And of course, relying on the patient's T cell response. So this is really remarkable. I know all three of us have commented today that it's just wonderful to have all these new options that we didn't have before, that we can target BCMA through multiple means, and we can do so with seeing significant response rates and durable benefit, some patients achieving MRD negativity and stringent complete remission. Although there's some unique toxicities we've had to learn. We've learned a lot about our eyes these last couple of years and CRS and other things like that. And we really have to work hard to improve the access to care. This is really unacceptable in many respects as to how many disparities there are, not just geographic, but many other disparities. And we hope with time that we can make this much more accessible to our patients as we go forward. So I want to just take a moment to thank our amazing speakers, Dr. Shah and Sidana. You've just been fantastic. I've really enjoyed listening to you and learning from you today and sharing this program. I want to thank the audience for listening today. Please Take the opportunity to claim your CME credits by completing the post-test and the evaluation form, which can be found in the tweets and the comments below. And make sure you follow Bonham CE on Twitter and stay tuned for other live stream and recordings and tutorials that are coming, even on BCMA-directed therapies. We have another one coming out very soon. So thank you again for your attention. We appreciate it.